Good evening, everyone. Welcome to the OLLI Medical Series. This is a weekly program where we have doctors come in from the neighborhood and talk about issues that are important to the senior population. Tonight we have Dr. Karen Bath, who will be speaking to us tonight with an update on Alzheimer's disease. She is a neurologist affiliated with the St. Jude Hospital. Her talk will discuss dementia, particularly Alzheimer's disease, and the treatments that are available. She will also discuss lifestyle modifications we can all do to decrease our risk of developing this debilitating condition. Okay, I'd like to introduce Dr. Karen Bath. I will stop sharing my screen. And Dr. Bath, if you'd like to share your screen and
figure out my screen sharing capabilities.
Was it on?
So we were just there, weren't we?
Do you need to restart PowerPoint?
Yeah, that's what I'm wondering.
Or Keynote?
I'm on Zoom and I just had the screen sharing. I'm sorry about this. I should know how to do this better.
That's okay. Zoom is an acquired skill.
I have my slides open.
You might need to touch or move your mouse to get the menu to pop up, and then you could find the green share screen button.
Okay. And now I got to the correct page. And almost there. There we go. Okay, hello everybody. Now that I've finally figured out my screen sharing, I'm Dr. Bath. I'm a neurologist here at St. Jude's Hospital. Can everybody hear me okay?
Yes, we can.
Okay, perfect. Well, I want to thank OLLI, Dr. Mutter, Mr. O'Reilly, Carol for inviting me to give this talk. Alzheimer's dementia is a topic that's very near and dear to me. And I welcome you all on this little journey we're about to take to understand a little bit better what dementia is, what the different stages of dementia are, what are the risk factors that increase our probability of getting dementia or Alzheimer's, and what we can do as individuals to decrease that risk. What the different treatment options are, we'll be touching on that as well. Some of you may be listening to this talk as a patient or as a loving caregiver or a friend who knows somebody who has Alzheimer's or who has dementia. And I welcome sharing information about this devastating disease and what we can do on an everyday basis to help things. So the objectives for this talk today is to define what is Alzheimer's and to characterize the disease spectrum, identify the different risk factors and different stages, and look at the outlook for new therapies as well. So what does it mean when your doctor says that you or a family member or somebody you know has Alzheimer's or has dementia? So what dementia means is having cognitive decline of a significant enough degree that it impairs your independent functioning. And Alzheimer's dementia is by far the commonest cause of dementia. As you can see on the little pie chart on the right-hand side, 2 out of every 3 people who are diagnosed with dementia, the cause tends to be Alzheimer's dementia, or it's dementia of the Alzheimer's type. Less than 1/3 is vascular dementia or post-stroke dementia. And then there tends to be an overlap between Alzheimer's and vascular dementia, which is about 10% of cases. There's less common causes of dementia, which includes things like Lewy body dementia, which is characterologically a little different. There's a lot of visual hallucinations, some degree of paranoia. There tend to be significant fluctuations from day to day in the symptoms. And there's motor symptoms that can be seen with it. Dementia associated with Parkinson's disease tends to develop later in the course of Parkinson's and tends to be a little bit different as well. Frontotemporal dementias, again, are a rare type of dementia where there's more difficulties with executive functioning, so more the frontal and the prefrontal portions of the brain, more difficulties with decision-making and executive functioning. And what does it mean when you hear somebody say that there is early Alzheimer's versus early onset Alzheimer's? Early onset Alzheimer's is defined by a hard number. So if onset of cognitive difficulties is before the age of 65, it's early onset Alzheimer's, versus if it's after the age of 65, it's late onset. Early Alzheimer's, now in a little bit, we'll talk about the different stages of dementia, what it means to have mild or early, moderate versus a late stage or advanced Alzheimer's dementia. But first, a little bit of history. So Alzheimer's, the first case of Alzheimer's was first described by Dr. Alois Alzheimer, who was a German physician, and described it in a patient who died in a woman called Ms. Dieter, Augusta Dieter, who passed after a progressive cognitive decline in her 50s. And you can see a picture of her up on the right-hand side. He described the brain pathology, which included amyloid plaques and neurofibrillary tangles that were seen on autopsy. It wasn't until many, many decades later that the beta amyloid protein was identified in our neighborhood at UCSD. The amyloid precursor protein was identified, and the gene was cloned in 1987. And it wasn't until 1996, which is 90 years after the first case was described, that the first medication was approved. And that was donepezil or Aricept, a name some of you may be familiar with. Then in 2000 and 2001 saw the approval of 2 other medications, which worked on the same receptor system and the same mechanism. And the last medicine to be approved for Alzheimer's was in 2003, which was memantine, which worked on a different mechanism, by a different mechanism. Since then, there have been a total of over 450 clinical trials and over 200 different chemical compounds which have been tested for Alzheimer's. And we have yet to have an approved medication since 2003. With every clinical trial that's not been successful, researchers have learned something new. They have learned new information and they've refined their work. Leading to currently at this current stage, we know more about the chemical and biological changes which go on in the brain many, many, many years before the onset of Alzheimer's, before the onset of actual memory changes. And we found that the most important thing is attacking the right target, so the right chemical, with the right medication at the right stage of the disease. And we'll talk about this in more detail later. And I believe that with all the information we have so far, we're at the brink of a breakthrough with Alzheimer's treatment. So as promised, the stages of Alzheimer's dementia. So clinically, when I evaluate somebody in the clinic for dementia, based on the MMSE testing, which is a 30-question questionnaire that we use to follow patients over time. We divide Alzheimer's dementia into mild, moderate, to severe. So with mild Alzheimer's dementia, there's memory loss is minor, but it's noticeable. There's changes in personality, which may be mild, and there's difficulty in higher order cognitive skills, so difficulty in organizing and expressing their thoughts, some word finding difficulties, family members may notice, some repeated questioning, some difficulty with remembering names of people you've met, some difficulty maybe in some hobbies that you used to do, which you find more difficult now. With moderate Alzheimer's dementia, there's a further progression in these cognitive difficulties with more dependence on the caregiver. There may be significant changes in personality and behavior, but are not necessary. Speech changes become more pronounced with more difficulty in word finding in normal conversation. With severe Alzheimer's, there's more of a loss of ability to communicate coherently. There may be a limited number of words that are used. There's a decline in physical abilities, so more automatic functioning, like with dressing, bathing, toileting. There's eventually a total dependence for even basic activities. And more practically, when patients ask what stage of dementia, there's a more practical staging system that's developed, and that's the Functional Assessment Staging Scale, which was developed at NYU Medical Center for Aging and Dementia Research, which defines more of a practical day-to-day staging, where stage 1, which you see in the yellow, is a normal adult with no functional decline, but there may be pathological changes in the brain going with deposition of beta amyloid, but no clinical functioning changes. The second stage is more aligned with what we call pre-dementia or mild cognitive impairment, where there is some awareness of functional decline by the person themselves without other people yet noticing it. So you may be noticing more difficulty with work activities, but you're able to use lists and make other rely more on your calendar, but are still able to do things that you need to do. Third stage is early Alzheimer's, where there's more of a functional decline. And for example, if we take work activities, other people may now notice that there's a little bit of difficulty with work organization. The more difficulty with organizational skills is noted at this stage. And people function at a 12-year-old stage. Next is the fourth stage, where there's more difficulty with complex tasks. Say, for example, planning dinner for multiple people coming in, or managing your finances requires more multitasking, and there may be more difficult in this fourth stage. Stage 5 and 6 are aligned more with moderate Alzheimer's and the previous staging system. And in this, there's more help needed with everyday functioning, like getting dressed or choosing. So at stage 5, there may be difficulty choosing what's the right kind of clothes to wear for the weather you're in or for what activity you're going to do. Whereas in stage 6, there may be difficulty just dressing yourself, putting on clothes the right way. Then there will be assistance needed for bathing, for toileting, what sequence of events needs to occur to toilet, to bathe, to regulate the temperature in the shower. There may be continence issues. And then the 7th stage is the most severe with the functional level of a newborn, where help is needed with all activities of daily living. So how big is this beast that we're dealing with? According to latest data, an estimated 46.8 million people worldwide are living with dementia. And this number is estimated to double every 20 years, with a projection of 131.5 million patients by 2050. About half of all individuals tend to be over the age of 85, and There's a disproportionate number of women. So about 2 out of every 3 patients are women. And there's different theories as to why this is. A part of it may be that as women, we live longer, and age seems to be the number one risk factor for development of Alzheimer's. Another may be that traditionally, back long time ago, women were less educated than men in patients who are now turning to be in their 70s and 80s. That statistic has changed in generations over time, but that may be playing a role as well. There's estimated over 9.9 million new cases of dementia each year worldwide, or 1 new case every 3.2 seconds in the world. And the worldwide cost of dementia care is staggering, with it responsible for 1% of global GDP. According to the Alzheimer's Association 2020 facts, Alzheimer's disease is the 6th leading cause of death in the United States. And more than 5 million Americans live with Alzheimer's. And by 2050, this number, could be significantly higher. Let's see. 1 in 3 seniors dies with Alzheimer's disease or another form of dementia. And medical care, even though has advanced, what we've seen since 2000 is that since 2000, the number of deaths from heart disease has decreased, the number of deaths from cancer has decreased, while the deaths from Alzheimer's disease have increased by 89%. And it kills more people than breast cancer and prostate cancer combined. And it's estimated that every 66 seconds, someone in the United States develops this disease. So these are projected numbers. These are, again, from the Alzheimer's Association facts and figures. And what that shows is projected number of patients with Alzheimer's over time. And basically what we need to see on here is that the in purple is patients aged 85 and over, and in yellow is 75 to 85. And that proportion proportion of patients over 85 is increasing over time, partially because we're doing a much better job of treating heart disease, cancer, and we're living longer. And we have a lot of work to do in changing this graph, because we have to do a better job in our brain health as well. So this is another graphic, basically showing that death from heart disease has decreased by 14% and this is from 2000. Death from stroke has decreased by 21%, from HIV by 54%, but from Alzheimer's, it's increasing exponentially. This was a graph which was actually formulated back in 2005, projecting every 5 years how the incidence of Alzheimer's is going to be, how the numbers are going to increase. So this was a graph back in 2005, and it estimated that by 2020, the number of patients would be worldwide 41.27 million. If we look at current numbers, we've already surpassed that number, and that number is currently more in the ballpark of 46.8 million. So we've already surpassed that. And if the projections continue, then by 2050, instead of 106 million people living with Alzheimer's, that number is going to be 131 million. So we certainly need to do something in decreasing that burden, decreasing that risk of getting Alzheimer's. So the big question, will I get it? Family history does play a role, but most cases of Alzheimer's are sporadic. If you have one first-degree relative with Alzheimer's disease, that confers a 20% lifetime risk. That means 80% of the time, even if you have a first-degree family member with Alzheimer's, you're not going to get Alzheimer's. But the risk is double that of the general population. If you have more than one family member, depending on how far that family member is from you, as far as first-degree, second-degree, the risk is higher. The number one gene that's associated with Alzheimer's dementia is the ApoE gene. Now we get one copy of this gene from each parent, and there's 3 different kinds of alleles. There's the ApoE2, E3, and E4. We get one copy from each parent, and ApoE4 is the bad guy here. So if you get one copy of ApoE4 from your parents, the risk of developing Alzheimer's dementia is 3-fold. If you have 2 copies, so one from each parent, the risk is 10-fold. Thankfully, the most common genetic incidence is the ApoE3, which does not increase risk. And ApoE2 actually has a protective effect. So may decrease the incidence of getting Alzheimer's dementia. 65% of patients with Alzheimer's dementia is said may be ApoE4 positive. And at this time, maybe genetic therapies need to be targeted at this, but we're not there yet. And this is the #1 risk factor for late onset Alzheimer's dementia. There are other genes that are responsible for early onset Alzheimer's, which include the presenilin mutations, amyloid precursor protein mutations. And in those, the onset of Alzheimer's tends to be under the age of 65. The incidence of MCI, or mild cognitive impairment, or pre-dementia is about 20% of those over the age of 65. But not all of them, not all of the patients with MCI will develop dementia. There was a meta-analysis looking at 41 studies done over time, and it was found that only about 38% of patients with MCI will develop dementia in the next 5 years. And at this stage, the most important thing that we can do is risk factor modification, is a lifestyle modification. That has a much more robust benefit in decreasing the likelihood of progressing from MCI to Alzheimer's than any medication. There was a clinical trial looking at acetylcholinesterase inhibitors, so the Aricept that is commonly used for Alzheimer's dementia, and it wasn't found that there was no significant benefit found in decreasing the likelihood of progression from MCI to Alzheimer's dementia. So what are the risk factors? Age is so far the strongest risk factor for development of dementia, particularly Alzheimer's dementia. The incidence doubles every 10 years after the age of 60, and approximately 85% of patients with dementia are older than 75. Family history plays a role, like we talked about with the ApoE gene, or whether, and especially for early onset Alzheimer's, when the onset is under the age of 65. Vascular risk factors play a big role. What are these? These are high blood pressure, diabetes, high cholesterol, smoking. The presence of all of these risk factors increases the incidence of all-cause dementia, of vascular dementia, as well as Alzheimer's dementia. So it's really important that these risk factors be controlled. So if somebody has diabetes, that we keep our sugars under tight control, under strict control. If somebody has hypertension, that the blood pressure stays well controlled. So risk factor modification, our vascular risk factor modification plays a major role. Then sleep. Importance of sleep cannot be underestimated. Memory consolidation occurs during deeper stages of sleep, stage 3 and 4 of sleep, as well as REM sleep. So not getting regular sleep, not getting deeper stages of sleep is an independent risk factor and does affect cognitive abilities. So say somebody has obstructive sleep apnea, which is not being treated, memory will be poorer the next day because you haven't gotten to the deeper stages of sleep. Exercise plays a big role, and we'll talk about this later as well. Regular exercise is protective for the brain. Lifestyle factors play a major role, and we'll talk about this in a little bit. So here are the risk factors for dementia. And this was a report that was sent out by Lancet in 2017, and they reviewed all the literature they had for modifiable risk factors. And I'll share the story of my two grandmas here. So I had a school-year grandma. She's since passed, but she was my grandma who we lived with, or who lived with us, but she liked to say we lived with her. She was a teeny little lady, under 6 feet tall, under 5 feet tall. She had the voice that carried across 7 houses through 2-foot thick brick walls. She didn't take nonsense from anyone. She took care of her diet. She always had this little box of nuts and her fresh fruit that she would have every day and nobody else could touch it. She was feisty. And then there was my summer grandma, who we visited with every summer, and every time we saw her, I saw her bent over the kitchen counter making something for her. She always making something for us. She always had lemonade or custard or some kind of dessert ready for us. She was the last person to eat after everybody else had eaten, and which included us, our parents, the neighborhood kids, the gardener, the maid. She developed hearing loss in her middle age, and it progressed further. She never got treated for it. And she spent a lot of her time either taking care of people, and her own health was the last on her mind. So with that in mind, with eventually later in life, just like a lot of stories, it's an ode to the unfairness of life. It was my summer grandma who developed Alzheimer's dementia. So taking all of that story in mind, let's look at the risk factors for dementia. What the Lancet found was 2 major inferences after looking at all of these different clinical studies that had been done. They found that no single intervention, no single risk factor modification was enough in delaying or preventing dementia, but intensive risk factor modification in middle life especially has the potential to delay or prevent a substantial number of dementia cases worldwide, and up to 35%. If you look at the second graph, which is kind of a zoomed in portion of the first one, I hope it's clear. It showed that up to 35% of that risk was modifiable. So some of those, and they identified these multiple risk factors, up to 9 potentially modifiable risk factors. So number 1 was education. So the higher the level of education, the more constant learning we have, the more you can decrease your risk. So which is kind of what we're doing here. It's never too late to keep learning. People can be college dropouts like Bill Gates was, and as long as you're you're a constant learner, you can keep dementia at bay. Midlife hypertension, midlife obesity, and hearing loss were independent risk factors for development of Alzheimer's dementia later in life. So if you have hearing loss, treat it, because the less input we have into our brain, the less processing of information, the less interconnections we form in our brain, and less brain reserve. Late life depression, diabetes, physical inactivity, and smoking were other risk factors, other modifiable risk factors for the development of Alzheimer's dementia later in life. Social isolation was another one. Other risk factors included.
We have a question in the chat room.
Yes.
They've heard that also it'll take many days. Excuse me. They've heard that Alzheimer's may take decades to develop.
Yes.
What is the current thinking on this?
So what we have found, looking at brain PET scans, which look at the deposition of beta amyloid in the brain, what can be seen is the deposition of beta amyloid can start 10 to 15 years, sometimes even 20 years before the onset of Alzheimer's. And part of that beta amyloid deposition may have to do with genetics, but part of that may have to do with lifestyle factors as well. So those pathologies in the brain, now the beta amyloid PET scans are only available through research, but there's also tau PET scans, which have been looked at in research. And that also shows that changes in tau protein levels are noted for years before the onset of cognitive difficulties. So, so yes, to whoever asked the question, you're correct in that changes develop years before. That's why the modification of these risk factors that we talked about is important earlier in life. The earlier you do it, the better it is, because you're decreasing that beta amyloid deposition speed over the years. So even with traumatic brain injury, like with boxers or people who play soccer, the more headers they did, the more subtle brain injury there was. On pathological specimens after autopsy, they were found to have more amount of beta amyloid in their brain. So traumatic brain injuries are another risk factor. So how can I prevent?
We have another question.
Yes.
Okay, Jody, go ahead.
Yeah, I had a couple of them. I've understood or I've read that you could have these amyloid deposits and still yet not develop dementia or Alzheimer's. And the other part of it is there any kind of a test to see if you do have them? Or if you are developing, is there some sort of test that would let us know, oh, those are on the horizon, they're there, do some things, do something.
Yes. So let me answer your second question first. So beta amyloid deposition and tau deposition, those are the two major protein changes in the brain that are associated with later development of dementia. There are PET scans. So these are nuclear medicine scans where the dye attached to a radionuclide goes and attaches to the beta amyloid in the brain or to the tau in the brain and lights up the brain. So those changes can be seen up to 10, 15 years before the development of any cognitive difficulties. And there are trials that have been done in patients who have a first-degree relative with Alzheimer's. I know UCI was doing it at one point, and that study is closed. And so it shows that there is beta amyloid deposition, and you may not have any cognitive difficulties at that time. So, but those are not commercially available yet. But may be available through clinical trials. There's the one that's available commercially is the glucose PET scan, or the FDG, fluorodeoxyglucose PET scan, where it goes and attaches, the radionuclide chemical goes and attaches to the brain in areas that have glucose metabolism. And it shows with early Alzheimer's that there is decrease in glucose metabolism in the brain, so decrease metabolic activity in the brain, in the frontal areas and the temporal areas of the brain. And this may be seen with only minimal changes in cognition, or this may be seen with pretty early on. That's available with commercially at this time. But again, if you have no cognitive difficulties, insurances won't cover it. And then to the second, the first part of the question, yes, there are things that we can do if you have a positive family history, if you have a positive PET scans, and we'll talk about some of those cognitive, some of those lifestyle changes that you can make.
Okay. Can we ask one more question?
Yes.
I've heard that Alzheimer's and dementia were two different conditions. What is the difference between the two?
So when we say Alzheimer's, it's more of a blanket term, like you have a big umbrella. And that's the example is saying, I have a headache. So I have a symptom. Dementia is, I have cognitive difficulties or memory difficulties of a severe enough degree that it's affecting my lifestyle. It's affecting my ability of independent functioning. And under that big umbrella are smaller umbrellas, which tell us what's the cause of that dementia. Like, what's the cause of a headache? Is it a headache because of migraine? Is it a headache from tension headaches? Is it a headache because I have a brain tumor? Is it a headache because I hit my head into the counter? So, so that's basically the classification. So dementia, when somebody says, I have dementia, it could be any cause. And 2 out of every 3 patients with dementia, the cause is Alzheimer's. Does that answer the question?
Okay, and there's one more.
Yes.
How do we treat hearing loss other than hearing aids?
Oh, that one, I don't know. There can be many different causes of hearing loss. You know, sometimes it could be external ear, just too much wax in the ear, you just accumulated too fast, and then the ENT physician would clear it out. But that would be more a question for an ENT doctor to see what else can be done to decrease progression of hearing loss. But I don't know.
Okay.
Okay.
That's all the questions we have right now. So.
Okay. So regular physical activity is really, really important. And if there's one lifestyle change that you can make to decrease your risk for developing dementia later in life, it is this. So if somebody said if I said I have a pill that will decrease with one treatment, would decrease your likelihood to develop or decrease the intensity with which you have high blood pressure, diabetes, high cholesterol, would improve mood, improve anxiety. Would you take it, and how much would you pay for it? That pill is physical activity. Okay, most people would be ready to take that pill, but taking a pill is easy. But the pill is regular physical activity, is regular physical exercise. Then next is cognitive training or lifelong learning, which is kind of what we're doing here. And then cardiovascular risk factor control, so control of diabetes, hypertension, obesity, smoking, high cholesterol. So let's talk about physical activity. There have been several studies that have found that physical activity in early, mid, or later life is associated with lower risk of cognitive decline and dementia. And people who exercise experience a slower progression of brain atrophy or shrinkage of the brain. There was a study done by Wake Forest University in North Carolina, and they compared stretching with rigorous physical exercise, so aerobic physical exercise, in patients who had mild cognitive impairment or pre-dementia. And the exercise that they did was 45 minutes a day, 4 days a week for 6 months. And at the end of it, they looked at brain architecture, and they found that in the patients, in MCI patients who did stick with this regimen, there was improved metabolism, there was improved blood flow in the prefrontal cortex, so in the frontal portion of the brain where your processing of complex information happens. There was no shrinkage of the brain noted in this area. And they did much better in cognitive tests than in patients in the control arm, which was the stretching arm. The stretching did help in body agility, but the normal aging changes that we would see with cognitive difficulties, with shrinkage of the brain, still continued to progress. So it did not have any protective effect on cognition or the brain. People who exercise regularly are less likely to have both cardiac as well as brain-related vascular disease, which is associated with the increased risk of Alzheimer's dementia. So you do a favor not just to your brain, but also to your heart when you exercise regularly. And it's never too late to start. The University of Pittsburgh looked at the older population, and they found that people who walked on a daily basis, they had larger brains and better cognitive function. And this is one area where, size does matter. So a larger brain would be associated in larger hippocampal volumes, which is where your short-term memory is housed, is associated with better cognition. And then the Framingham study, which was basically it's the largest prospective study where they took one big town in New England, Framingham, started monitoring people from 1948 onwards, and now they're at that third generation of people. They found that daily brisk walks decreased the chances of getting Alzheimer's, decreased the risk of Alzheimer's by up to 40%. So physical activity is the most important thing. Cognitive activity or brain training. This is quite broad and can include a variety of activities, like, people do crossword puzzles or learning a new language or reading a book, or undertaking a further education, taking courses, college courses later in life. So all of these have a protective effect. The most important, what these activities do is they increase your brain reserve because they help form new connections in the brain. So say one big road or one major highway or major connection is blocked because of an amyloid plaque or because you had a small stroke in that area. If you have more connections in your brain, you can bypass that area and still be able to connect one part of the brain to another because you have more connections, more synapses in your brain. The computerized brain training is only modestly effective in improving cognitive performance. It will be more helpful to, say, learn dance or learn a new language, because you involve many new areas of the brain, forming connections between different areas of the brain. Let's take language, for instance. Say you decide to learn a new language. You're using the auditory portion of your brain where you're hearing the words, hearing the sounds. You're involving the memory portion of your brain where you're memorizing those new words. You're enunciating the new words in a new way with a new pronunciation. So your cerebellum and the basal ganglia is involved in that as well. You're connecting a word to a meaning and retrieving that information later. So that involves your prefrontal areas of the brain. So you're involving multiple brain areas. Same with learning, going to learn dance. That involves, again, memory processing. You're learning the sequence of steps, and learning sequential steps is part of not just your hippocampus, where your short-term memory is, but also frontal, prefrontal area of the brain. It also involves the motor portion of the brain, where you're learning what step, how to move a certain way to learn your next dance steps. It involves the cerebellum and the basal ganglia, which is more for finer coordination as well. And plus it gives you physical activity in addition. So if you're going to do one new brain training activity, it would be, I would vote for dance. So new activities, the more portions of the brain they involve, the better it is for developing brain reserve. Next, looking at diet. So far, out of all the diets out there, the Mediterranean diet has the most has the most data. This is a diet rich in fruits, vegetables, olive oil, legumes, whole grains, and fish. And studies have shown that people who follow the Mediterranean diet are less likely to have Alzheimer's than those who don't. It slows cognitive decline in older adults and reduces the risk of progression of MCI and Alzheimer's dementia. Then there's the DASH diet in addition. So DASH diet was the full form is Dietary Approach to Stop Hypertension. It was developed by the Mayo Clinic. So it's a low salt diet, rich in potassium, calcium, magnesium, decreases the risk of high blood pressure, heart disease, cancer, osteoporosis, and also decreases the risk of developing Alzheimer's. Then there's the MIND diet, which is a modified Mediterranean diet. It's a combination of the DASH diet and the Mediterranean diet. And this was developed at Rush University in Chicago. And this is the diet that's recommended by the Alzheimer's Association as well. And it's been found that the neurocognitive delay, slowing down neurodegenerative disorders like Alzheimer's dementia, it does a better job than both the DASH and the Mediterranean diet. So those are, things you can find online easily as to what are the components of those diets. And the most important thing, if there's one change that you would make in your diet, it would be to cut out sugars. That would be the number one thing that you can do. Alzheimer's dementia, by some researchers, by some clinicians, it has been also called type 3 diabetes, because it's been thought that it is a change in glucose metabolism of the brain that increases your Alzheimer's disease risk, or that changes with Alzheimer's disease. There are other supplements, over-the-counter drugs, which sometimes patients will come and ask me about. There have been clinical trials done for some of them. And so far, clinical trials have not shown any clear benefit for ginkgo, B vitamins, vitamin C, NSAIDs or anti-inflammatory medications, huperzine, which is a Chinese herb. There are some supplements that have shown mixed results. So the omega-3 fatty acids. So the ADCS, or the Alzheimer's Disease Cooperative Study, which which is based in UC San Diego, showed this was done for mild to moderate Alzheimer's disease, and they found that patients taking 2 grams of DHA fared no better overall than those who took a placebo. There's a possibility that this study, if done for longer, would have shown a benefit, and maybe it may require a longer study to see those changes. Memory, there's a MIDAS study, which again enrolled older adults with normal age-related cognitive decline, compared to the mild to moderate Alzheimer's dementia that patients that had been taken with the ADCS study. And this, in this population with normal age-related cognitive decline, these patients did better on memory testing than those who got placebo. So the DHA did show a benefit in this population. Again, vitamin E is another one that has shown really mixed results. A 2012 review showed no benefit, but then 2014 VA study showed on the one side that there was a benefit in activities of daily living in patients who took vitamin E, but in the subgroup that took vitamin E along with memantine, there was, the ADLs, or activities of daily living, actually worsened. So we don't know what to make of that. So further studies are needed. There is a supplement called phosphatidylserine, which had shown some benefit in earlier studies, but this benefit was only short-lasting, lasted only a few months, and was seen only in a small proportion of patients with milder symptoms. So really no lasting benefits, and no further studies have been done. Some patients will ask about Axona, which is a supplement. It's marketed as a medical food. It's basically medium chain triglycerides, caprylic acid, which is needed, which is seen in coconut oil or palm kernel oil, and it's broken down into ketone bodies and provides an alternate source of energy for neurons, as opposed to glucose. The phase 2 study that was done had shown that it was better than placebo in tests of memory and overall function, but a bigger study was needed. And in 2013, the FDA actually gave them a warning, saying that they were marketing, that they could no longer market it as a medical food, because it really had not shown significant benefit. And so the company did a bigger study, which in 2017 did not show any benefit. So overall, it doesn't seem to be beneficial. And I've had patients who have tried it and have had difficult time tolerating it because of GI-related side effects. So stomach bloating, diarrhea. Prevagen is another one that's been marketed heavily. as clinically proven to improve cognitive function. But the study that they have on their website is a study that was run by their own company, by their own researchers, and printed on their own company's journal and not in any peer-reviewed journal. So it's not a study that can be trusted by itself without the need for further studies. And the Federal Trade Commission actually charged the company with false advertising back in 2012. So practically, where are we? You know, where are we going? So this is a video, I don't know if it will come through, which talks about how Alzheimer's is progressing. Let me know if you can hear it or not.
Complex chemical and electrical processes take place within our brain.
You could hear it.
Let us speak, move, see, remember, feel emotions, and make decisions. Inside a normal, healthy brain, billions of cells called neurons constantly communicate with one another. They receive messages from each other as electrical charges travel down the axon to the end of the neuron. The electrical charges release chemical messengers called neurotransmitters. The transmitters move across microscopic gaps or synapses between neurons. They bind to receptor sites on the dendrites of the next neuron. This cellular circuitry enables communication within the brain. Healthy neurotransmission is important for the brain to function well. Alzheimer's disease disrupts this intricate interplay. By compromising the ability of neurons to communicate with one another, the disease over time destroys memory and thinking skills. Scientific research has revealed some of the brain changes that take place in Alzheimer's disease. Abnormal structures called beta amyloid plaques and neurofibrillary tangles are classic biological hallmarks of the disease. Plaques form when specific proteins in the neuron's cell membrane are processed differently. Normally, an enzyme called alpha secretase snips amyloid precursor protein, or APP, releasing a fragment. A second enzyme, gamma secretase, also snips APP in another place. These released fragments are thought to benefit neurons. In Alzheimer's disease, the first cut is made most often by another enzyme, beta secretase. That, combined with the cut made by gamma secretase, results in the release of short fragments of APP called beta amyloid. When these fragments clump together, they become toxic and interfere with the function of neurons. As more fragments are added, these oligomers increase in size and become insoluble, eventually forming beta amyloid plaques. Neurofibrillary tangles are made when a protein called tau is modified. In normal brain cells, tau stabilizes structures critical to the cell's internal transport system. Nutrients and other cellular cargo are carried up and down the structures called microtubules to all parts of the neuron. In Alzheimer's disease, abnormal tau separates from the microtubules, causing them to fall apart. Strands of this tau combine to form tangles inside the neuron, disabling the transport system and destroying the cell. Neurons in certain brain regions disconnect from each other and eventually die, causing memory loss. As these processes continue, the brain shrinks and loses function. We now know a great deal about changes that take place in the brain with Alzheimer's disease, but there is still much to learn. What other changes are taking place in the aging brain and its cells? And what influence do other diseases, genetics, and lifestyle factors have on the risk of developing Alzheimer's disease as the brain and body age? Scientific research is helping to unravel the mystery of Alzheimer's and related brain disorders. As we learn more, researchers move ever closer to discovering ways to treat and ultimately prevent this devastating fatal disease.
So let's go back. So this is a pictorial representation of the same. This is from the Canadian Medical Association. And this shows, again, the alpha secretase, which normally breaks it down. This is the normal mechanism. And this, on the other side, is the abnormal mechanism where the beta amyloid, which my daughter says looks like a hot dog, is released into the brain because it's broken down the wrong way. And it connects together, forming oligomers, which are at first soluble. And then as the sheets get bigger and bigger, they become insoluble and affect the ability of one neuron to talk to another. So when we look at the whole brain, you can see that compared to the normal brain, a brain with Alzheimer's looks much more shrunken. And the presence of these amyloid, and if we look at this graph, what it basically shows is the yellow line shows the amyloid plaque deposition, and the red line shows the development of dementia. And you can see that if you look at the bottom, these are the number of years. There's at least 10 to 15 years time lag between development of deposition of beta amyloid in the brain and the development of memory difficulties. So what's the treatment? The currently available therapies for Alzheimer's target two main neurochemicals in the brain. First is acetylcholine. And that's because the acetylcholine producing neurons are lost in Alzheimer's. So the theory is you increase the availability of acetylcholine and you improve and maintain your cognitive function for a little bit longer. And the second is a neurotransmitter or chemical is glutamate, which is an excitatory neurotransmitter. And too much glutamate stimulation impairs learning and causes neuronal damage from excitotoxicity. So the medications, the disease-modifying therapies, which work on the acetylcholine receptors, are the donepezil or Aricept, rivastigmine or Exelon, and galantamine. And then the NMDA receptor antagonist, which is memantine, it's the only drug in its class. And the remaining drug therapy for Alzheimer's is treatment of the neuropsychiatric symptoms. So if you have trouble with sleep regulation, or there may be sleep aids needed. If there is difficulty with paranoia, agitation, or psychosis, hallucinations, there may be medications needed for that. Antipsychotic medications may be needed for that. If there's obsessive behaviors, repeated checking, picking behavior, sometimes not wanting to bathe or not wanting to change your clothes and wanting to wear the same clothes over and over again. There can be many different kinds of obsessive behaviors. Then there may be medications needed to treat that. And that includes SSRIs, medications that are used for OCD as well. These are the different medications we talked about. Sometimes for agitation, there are medications that like Depakote or lamotrigine that can be used for off-label for the agitation. Nudexta is a medication that is approved for pseudobulbar affect, and this is a dysregulation of emotional expression. So that can be inappropriate laughing or inappropriate crying by minor stimuli and difficulty in controlling the extent of that emotion. So what is the drug development process? So any drug that goes through, any medication that ends up being approved needs to go through all these different stages. So step one is discovery and development. So look at the mechanism, look at any disease and the different chemicals, neurotransmitters, abnormal proteins involved in it, and target it. So discovery and development, and then preclinical research, which is step two. So which may be in vitro, so in petri dishes, or in vivo, that means animal studies. Next step is a step three, which is clinical research. So phase one looks at clinical trials usually done with either healthy volunteers or volunteers with the disease. These studies last a few months, and their main aim for phase 1 studies is to look at safety and dosage. So different dosage strengths are usually checked. Out of all the drugs tested, about 30% of the drugs moved on to the next phase, which is phase 2 studies. This is done with patients with the disease, and this involves several hundred patients. Studies may last from a few months to up to 2 years. And in this phase of the study, our aim is to check for efficacy, so how effective the medication is, and what are the side effects. So safety and dosage is checked with phase 1 studies, efficacy and side effects with phase 2 studies, and about 14% of those drugs move on to the next phase. And next, they move on to phase 3, which are the gold standard studies. FDA usually requires at least 2 different phase 3 studies, which would be placebo-controlled before any medication is approved. And to get to phase 3, you need to pass through phase 1 and phase 2, as well as, of course, the preclinical studies. These studies usually last for 1 to 4 years and involve usually thousands of volunteer patients with the disease. This tests for efficacy and side effects. So whatever signal was seen in the phase 2 studies, that gets looked at in a bigger view with phase 3 studies. And 9% of the drugs that go through this phase get submitted to the FDA for approval. Phase 4 is the post-marketing phase. That's after the drug is put into the market. It's approved by the FDA. It's still followed. Those patients are still followed for 11 to 14 years after that, and several thousand patients with the disease are followed. Again, looking for any long-term safety signals that may show up after years of use. So this is going back to the person who asked that question. As to what changes happen in the brain years before. Years before the cognitive difficulties start. So when you're looking at this slide, it is showing, the first section is there is no pathology in the brain, there is no disease. So any interventions we make at this phase is primary for prevention. That is, any interventions we make at this stage is going to keep Alzheimer's pathology from even occurring. Whether it's your education, whether it's learning, whether it's control of high blood pressure, diabetes, hearing loss. So all of those will be primary prevention. Secondary prevention is once we already have the pathology setting in, but the disease hasn't occurred yet. So this is the preclinical stage. The red line that you see is deposition of beta amyloid in the brain. The yellow line is the synaptic dysfunction. So that means you're seeing changes on the fluorodeoxy PET scans. Those are the commercially available PET scans in the market. And then the blue line is looking at tau deposition, which you heard about in the video. It's the abnormal neurofibrillary tangle protein that deposits in the brain. And all of these changes are seen preclinically even before the dementia develops. In the last 2 blocks, you can see that this is MCI, or mild cognitive impairment. That's pre-dementia. That means some cognitive difficulties are noted, but independent functioning is maintained. And then dementia that develops after. You can see that the development of dementia and mild cognitive impairment is much later than the pathology that is seen in the brain. So if you have a drug that targets beta amyloid, that needs to be instituted early. So we're talking about what stage of the disease, what chemical has to be used depends on what stage of disease you're at. So when they did the initial clinical trials on medications that were targeting beta amyloid, they found that the PET scans can look beautiful after treatment. So you can remove all the beta amyloid that you want with those medications. However, there was no cognitive improvement in patients who were already at the moderate to severe stage of Alzheimer's. because too much damage has already occurred. So now these medications are only being tested in either mild Alzheimer's or even in the pre-dementia mild cognitive impairment phase. And the day is not far where once we have that piece of the puzzle solved, we may be testing patients for the beta amyloid deposition even in the preclinical stages, before there's any dementia developed or any mild cognitive impairment developed, and remove the beta amyloid before it's had a chance to cause more significant damage. There are clinical trials looking at medications that target tau proteins as well. And this chart was developed by the US Department of Health and Human Services by the Advisory Council on the Alzheimer's Research, Care, and Services. The second graph looks at the same thing. It's a zoom in on the same graph, looking at this is beta amyloid deposition, which starts in the preclinical stage. This is the fluorodeoxy PET scan. That means glucose metabolism in the brain or functional MRI changes. This is tau deposition. So if tau is to be targeted, it will be at a somewhat later stage than the beta amyloid target. The blue is the brain structure. So it means the shrinkage of the brain that we see on scans, which can be seen in patients, even in people who even don't have cognitive difficulties. So, but we can see that this develops much later after beta amyloid, after tau deposition, after changes in brain metabolism. The purple is the cognitive difficulties, which you can see develops after, and then clinical function. So independent functioning is affected last. So these are some of the active clinical trials that we're conducting at Neurology Center of North Orange County. You can see here, most of these trials are targeting mild Alzheimer's dementia. So early symptomatic, mild cognitive impairment. Most of these drugs target the mild cognitive impairment or the mild Alzheimer's dementia, because this is where we can make a dent. The aducanumab, the IMBAC study, that's only enrolling patients who were previously in the study because it has shown good benefit and it's pending FDA approval. Participation is by invitation only, by usually study participants from before. There is only one study currently ongoing that targets mild to moderate Alzheimer's, and this is targeting more the brain metabolism, the more of a neurotoxicity marker. And so in summary, the pathophysiological process of Alzheimer's begins well before the clinical decline in memory. And it can happen more than a decade before the development of dementia. Both amyloid accumulation and neurodegeneration are required for cognitive decline. Sensitive imaging and cognitive measures can track progression in the preclinical stages of Alzheimer's. So neuropsych testing or deeper cognitive testing will catch those cognitive difficulties, which are very subtle. Lifestyle factors matter, people. This is the most important thing that you can do with yourself, is lifestyle factor modification. And it's really important that we must consider treating Alzheimer's dementia much earlier and use combination therapies to increase our chances of success. Targeting both the neurotransmitters, both acetylcholine as well as the NMDA, synergistically have shown an added benefit in people whose cognition is progressively worsening. All of these medications that are currently FDA approved, they slow down cognitive decline. They do not stop cognitive decline. Therefore, it's really important that we start treatment early, because the more we have, the more we preserve. So it's really important to talk to your doctor about cognitive difficulties that you may be noting, and to target treatment of that early, where and it may be lifestyle modification and closer monitoring of those lifestyle factors, of those vascular risk factors that may accelerate the progression. So This is my summer grandma and my daughter here. And this is from an anonymous, this is a quote from an anonymous source by a patient who says, "I have dementia. My eyes do see, my ears do hear. I am still me, so let's be clear. My memory may fade, my walk may slow, but I'm me inside. Don't let me go." So if somebody you know is forgetful, has trouble with memory, there are lifestyle factor modifications. There are things you can do that are in your control. And I encourage you to talk to each other, to talk to your doctor, to treat the risk factors that we talked about, to think about clinical trials, if that's the route that you would want to move in, or to look and to treat it early, to treat Alzheimer's early. And I think that is my last slide. So I will.
Thank you for that. We do have some questions in the chat.
Yes.
How do you confirm a diagnosis of Alzheimer's while the person is still alive, as opposed to just having dementia?
So at this time, diagnosis of Alzheimer's is purely clinical. I say when a patient comes to me, my first job, my first step is to rule out other causes of cognitive impairment, to rule out the reversible causes of cognitive impairment. Check your vitamin B12 level, check your hormone levels, check your other vitamin levels, your B1, your folic acid, things that can cause difficulty with memory, with cognition. We rule out those things. We'll usually do brain imaging to rule out vascular dementia. To look at, whether there's presence of any strokes in eloquent areas of the brain that can affect your cognition. So a lot of workup of dementia, Alzheimer's, diagnosis of Alzheimer's is based on ruling out other things. And once we've ruled out those things, then I would follow the patient over time. And we do cognitive testing, whether it's MMSEs or whether it's MoCA testing, and follow a patient over time. And if we're seeing a gradually progressive, creeping decrease in cognition, that leads us to a diagnosis of Alzheimer's. Then there are supportive tests that can be done, and those include the PET scans. Like I said, the beta amyloid PET scans and the tau PET scans are only available through clinical research. However, the fluorodeoxy PET scans, which we used to have the hardest time getting insurance to approve, are now they're doing a better job of approving those. So that's an additional test that sometimes can be done when there's a confusion in the clinical picture. Say somebody has had history of traumatic brain injury, there's significant medications that may cause cognitive difficulties, or there may be judgment errors, and we're suspecting, could it be frontotemporal dementia versus Alzheimer's? So in that case, we can get the FDG PET approved, and that would give us additional evidence.
Okay. While exercising, do you need to reach a particular heart rate, or is any exercise good?
Exercise is always good, but it's the aerobic physical exercise. So where you get to your heart rate, your heart beating faster, you're breathing faster, so reaching 70 to 80% of max heart rate. So it is the aerobic physical exercise, so the brisk walking rather than a slow stroll, that has been found to improve cognition. So it's anything that improves circulation to the brain and improves circulation to the heart, increases cardiovascular health, but also helps remove some of those toxins from the brain. So it has to be brisk walking, and at the very least.
Okay. Has anything been proved regarding not using aluminum foil?
It used to be said that the aluminum was an additional risk factor, and it was more to do with the fillings that we had in our teeth, which had aluminum in them. And nowadays there's lesser and lesser amount of that being used, as in it's more porcelain fillings than amalgam based fillings. But it's rare to have, even if we do heavy metal testing, it's rare to see aluminum levels to be higher. Lead by itself can also, so it depends on what profession, what line of work you were in. So if you were in a line of work that involves smelting and exposure to heavy metals, then yes, that may be playing a role. But normal everyday life, it's really not been found to increase your blood aluminum levels.
Okay. Can you speak to the ATH trial? What mechanism is it targeting, and what are the side effects?
That's looking at the neurotoxicity mechanism and works more on the NMDA receptor. So that's why usually in patients, it's not used concurrently in patients who are also on memantine, which targets the same receptor. So it's for early to mid in patients who are not on the memantine. So because it's also targeting neurotoxicity. So we don't want to cause more side effects because there are two chemicals that are targeting the same chemical compound in the brain.
Okay, and why is it injected rather than any other form?
I would have to, it depends on the mechanism of action of the drug. And let me see, was that the injected one? Thera. Okay. I don't know. It depends on how the drug's half-life is and what the bioavailability is. A lot of times, sometimes the drugs, when you take them orally, they get broken down by the stomach acid and are not absorbed. So this may be the way of getting the drug into the circulation.
Okay. Well, that's all the questions that we have right now. I want to thank you for talking with us tonight.
Of course, and thank you for giving me the opportunity to do so. I think it's a very important topic and it's a very important disease to target. And all of us, by making these changes in our life, in these lifestyle factor modifications in the life of our loved ones, can decrease that disease burden.
Okay.
So, thank you all.
Thank you. And to the class, people in the class, we have two students from the Fullerton nursing program. They would like to interview some of the OLLI members. We're looking for 2 volunteers to sit down over Zoom or on the phone and talk with these people. They need to do this as part of their training to talk about interviewing people. So if you're interested, you can indicate it in the chat or raise your Zoom hand and we'll get you together with these people. Okay, so thank you, Dr. Bath. And our next medical series will be next week at 9 a.m. and we'll talk about thyroid function in the mature population. So thank you.
Thank you and good night.
Good night.
Thank you.
Thank you very much.
So if the people that are interested in talking to the students, if you want to stay on, and we'll get you together with them.
Is that for tonight?
I don't know.
Hello, hi. I'm one of the nursing students. I'm Jules. So if it's too late tonight, what I can do is if Bill can open up the chat, if someone wants to share their email with me, and then I could exchange that information and we could set up a Zoom time that works best with you guys. But so I don't know if you could see Jerome in the room too, but we need just one person each to interview and just get some experience and info from you guys. So
How much time are you looking
You
at?
have to have all volunteered.
What's the length of the interview?
Right. Good question.
The interview isn't too long. It's basically just asking about a little bit of background about your life, about your lifestyle right now. So the length really depends on how in depth you want to answer the questions.
I'd
So
say
it's
maybe
about,
30
it's
minutes.
about a half
Volunteer.
hour. I've
Hello.
already done it.
I could participate.
And I can participate.
Okay, so if you could put your email address in the chat room, if you know how to do that. And
Yep.
then,
I could do it right now if one of them wants.
let me go ahead and stop the recording here first, so we don't get this on the recording.
Bill, you're also streaming.
Yes, I stopped that also.